This talk is called Understanding Your Epilepsy. And as this event has many messages that we're trying to convey, one of the big ones is that it's an unfortunate situation that too many people with epilepsy do not get to see epileptologists. They go to general neurologists. They do the best they can, but it's not as effective as seeing an epileptologist who really gets to the root, figures out what type of epilepsy you actually have, and then gets you on a better treatment plan. So, without wasting any more time, I'm going to call up Dr. David Millett, the new director of the epilepsy program at Hoag Hospital, and he's going to talk to you about understanding your epilepsy.
Thank you, Brad. Can I turn it off? I can probably speak loud enough. Just, yeah. Great. Can you all hear me? Can anyone not hear me? Because I'm pretty loud. Microphone? Better? Yeah. Thank you all for coming, and thank you, Brad, for organizing. My name's David Mallette. I know some of you, I believe. I'm not sure if this thing is on, though. You got it? Good. I know some of you have had the pleasure of seeing you in clinic or taking care of you. This speaker's corner last year was 7 bar stools in a corner of the ballroom, and that was kind of fun. And this is a little bit different. But it's certainly nice to see some new faces and a lot of folks coming through. I'm an epileptologist. I am a recent addition to Orange County. I was born and raised in Los Angeles, and I trained at UCLA. I spent 8 years building a program, an epilepsy program for the county of Los Angeles, and about 1.5 years ago moved to Orange County to become the director of the epilepsy program at Hoag, with the hopes of developing a multi-hospital system of care for epilepsy amongst the St. Joe's Hoag Hospital network. Giving this talk last year was a little bit easier because there were many fewer talks. There were probably 6 or 7. Brad's gone. He'll remember how many there were last year, but it wasn't that many. And you all have heard some really eloquent and expert opinions and speakers on various topics relating to epilepsy. I'll give you a bit of a kind of a personal take on epilepsy and understanding your epilepsy. This is a ridiculously complicated disease. I mean, I'll say that again. This is a ridiculously complicated disease. Seizures can look like anything. I've had patients whose seizures looked like that. And we all know what generalized tonic-clonic seizures look like, and most of you know what complex partial seizures and absence seizures look like, and you've sort of lived through them. But from the epileptologist's eye, you just have to recognize a very broad variety of seizure types, and keep in mind that about 1/3 of patients who are referred to an epilepsy monitoring unit at Hoag or UCLA or USC turn out not to have epilepsy at all. So the problem that we deal with in taking care of our patients with epilepsy is magnified by the dilution or pollution of all the patients who have spells that look like seizures but turn out not to be. So it's a very challenging disease to diagnose from the clinical standpoint. So I told you seizures can look like anything, and epilepsy can be caused by almost anything. We all know that there are gene mutations, there's trauma, there's lack of oxygen, there's perinatal strokes, there's infections, there are well-defined genetic diseases like tuberous sclerosis, there's autoimmune syndromes. Rasmussen's was discussed in the last session with our surgeons. So the causes or potential causes of epilepsy are almost as variable as the different types of seizures that we can see. Then add to that the fact that there are over 20 anticonvulsant medications on the market. Those medications have what I call the 80-20 rule. 80% of patients read the package insert and more or less have the side effects that the FDA says that they should, and the other 20% read the package insert and do the opposite thing. And so it makes it really complicated sometimes to understand when you prescribe Lamictal for somebody because you think it's a great anticonvulsant and a great mood stabilizer or antidepressant, and they suddenly become suicidal on you. What happened? Why is that? And you have to take into account the fact that not everybody reacts to medications in exactly the way that they're supposed to. So beyond medications, of course, in 2015, we have traditional surgery. We have minimally invasive surgery, and that comes in various forms. We had gamma knife radiotherapy for a while, and we have two forms of neurostimulation. We have VNS and we have RNS, responsive neurostimulation, if you can identify the focus or foci in the brain that are creating the seizures but can't resect them for one reason or another. And then we have dietary therapy. So most of you may have heard of that as ketogenic diet, but now there's modified Atkins diet. There's some evidence for low glycemic index diet as a mechanism to manage seizures. So it's really, really complicated. I like to refer to it as ridiculously complicated. But the starting point in all of that, in understanding which therapies are likely to succeed and which are not likely to succeed, is really understanding your epilepsy. And in understanding your epilepsy, that really requires, number one, an epileptologist. General neurologists usually don't have the time, nor do they have the access to resources. That means long-term EEG, whether that's inpatient or outpatient, and epilepsy protocol MRIs. And the time to sit down and take a very careful history and understand what people's spells or seizures or events look like and what they experience during them, and put that all together. And you could pick any one of those three things, the clinical history, the MRI, the EEG, and I can explain why it makes such a huge difference to come to an epileptologist. But the biggest thing the biggest issue that people come to me with is they say, I just had an MRI last week or last month or last year by my community neurologist and it was normal. So there's no reason, there's no scar, there's no malformation, they can't figure out why I have epilepsy. And I can tell you that that community MRI done in some imaging center out there has about 250 images on it. It's in about 5 sequences. Our epilepsy protocol MRIs, whether they're at Hoag, USC, UCLA, will probably have 11 or 12 sequences and be comprised of 1,200 images. So you're taking a very, very narrow view of what a brain looks like when you go to an imaging center that's not used to doing epilepsy level care. It's really important to go to a place that can take the time, get a clinical history, order the proper MRI, and do an adequate amount of brainwave or EEG sampling to begin to put it together and find out whether this patient has primary generalized epilepsy, focal epilepsy such as temporal lobe, either with or without a scar involved, focal cortical dysplasia, and then understand what the treatment options are. Medications, surgery, diet. That's what epileptologists do. That's what we try to spend most of our day doing in the clinics and in the hospitals. And I've had the good fortune to train at UCLA to build a program in the county in Los Angeles, where we saw many hundreds of patients come through our clinics every week and every month, and now to do the same thing here at Hoag. So many of the speakers before me today really touched on critical aspects of epilepsy care, and our time here is limited. Are there particular questions that people have about how to go about finding an epileptologist or how to understand their particular diagnosis? And we can start, please.
How do you get referred to one when your either emergency room doctor or your general practitioner doctor refers you to a neurologist? I mean, I had no idea that your line of work even existed. And so how would I work my way to getting to someone like yourself? Actually, it would be you, but...
So there are a handful of epileptologists in the community, but most of them are associated with comprehensive epilepsy centers, and most of those are in university settings. So you would, when you see your neurologist, ask to be referred to an epilepsy seizure specialist. Okay. That's the easiest way. Okay. Unfortunately, what happens at that point in time is largely dictated by insurance plans. And that's the part of being a doctor, unfortunately, that we have little control over and is often the most frustrating for us and our patients. I've had patients who come to me out of network, either paid or we had to go through this complicated letter of agreement with their providers, and then I order tests and they want to do the MRI here and the PET scan there, and they won't authorize the inpatient EEG. So it can be very challenging to coordinate all that care, but it's really critical to do so.
Well, and would the fact to support that be that you've gone through all the others and they find there's nothing wrong? But if you were to have like 3 grand malls within a year and then continue to tell you there's nothing wrong, it's like, okay, well, I think I have a little bit of common sense. To me, I would have to say, until you can show me you've done every test that you can possibly do to determine that in fact there is nothing wrong and we don't know why. Sure. I wouldn't be as accepted. So for me, yep. Would that support getting to somebody like yourself?
I would say so. I would say if you continue to suffer from seizures that cannot be controlled with medications or have unacceptable side effects, even though your seizures are controlled, that either one of those scenarios would be an appropriate reason to be referred to an epileptologist.
Thank you.
Please.
A question.
Yes.
Yeah, my son went to Moet and they get EEG and then also the MRI.
Okay.
And he had 3 seizures in 3 months, once a month.
Okay.
And then if nothing showed, everything was okay.
Okay.
But still because of the 3 episodes, yeah, he is on the camera. But are there any other tests that to make sure he really has problem? Or because I have my few doctors, my family,
okay.
My brother, they said you need to make sure like a blood test or other tests to make sure. So I'm not sure. They are just normal doctor. They are not like specialists like you. So any other suggestion that you can give me, please?
So I think that there are short-term, maybe intermediate, and then long-term goals. In the short term, 1 seizure a month for 3 months, you want seizure control, right? You don't want your child or your loved one to suffer any more seizures. There are all kinds of risks. SUDEP was discussed earlier today, all kinds of risks associated with breakthrough seizures. So you obviously want a period of time, presumably on medication, in which your child is seizure-free. Once that time has elapsed, and that time is usually a year minimum, more often 2 or more years, as long as they're able to tolerate the medications, it's probably time to reassess. There are a few forms of childhood epilepsy that patients will outgrow. Absence epilepsy, for the most part, patients will outgrow the staring spells at 5, will be gone by 12.
My son is 18.
So there are adolescent forms of the pediatric epilepsies that don't usually outgrow them, but often can be well controlled with medication. But so if I were to hear that story, the the kind of testing that I think would be most important would be EEG testing at this point in time. And again, compare what happens usually in the community to what happens in an epilepsy center. So in the community, a neurologist would write for an EEG. That's usually a 20-minute study. Sometimes they'll order it sleep deprived. The patient will be usually awake for the first 5 or 10 minutes. You'll capture 5 minutes of sleep, and then they'll wake them up to shine the strobe lights or do the hyperventilation, right? So in the university setting, and in the past, when it was really, we were limited by, we had paper EEG, or computers had not really been developed, and analysis of EEG was difficult, or storage of data was difficult. You get one 20-minute EEG. If that was negative, you'd order another 20-minute EEG. And the rule of thumb was you get three 20-minute EEGs. So you got to hook on those leads every time, and has to be interpreted and come back in a month or 2 months or 3 months. What I do in my practice is I order an outpatient 40-minute EEG because I'm guaranteed to get at least 15-20 minutes of sleep, which is a very important state to capture epileptic abnormality. And if that's negative, if I don't see anything on that, and I still have a suspicion of epilepsy, I'll order a 24-hour or 48-hour home study. And that gives me 100 times more data than what the typical community neurologist would get on a 20-minute EEG. So your sense of certainty about whether you're dealing with epilepsy and what type of epilepsy you're dealing with goes way up for the physician and hopefully for the patient and the family once you have adequate amount of data.
Okay, doctor. So I will get.
Does that make sense?
Yeah, he did have EEG
Yeah.
at home, but I don't know how many minutes.
Yeah.
Because referred by another
Yeah, it's-
doctor.
yeah.
I'm planning to see
Yeah.
anyway. I had 3 months waiting, so I said I'm excited to go to university. So
Yeah.
okay, thank you very much.
Was there another? Yes, please.
So, can you have a epileptologist and a neurologist? Is it typical to have both of those doctors or do you have to go one from the other? And then also, the MRI and the EEG, is that just based upon the doctor's bill and need, or is it like, well, you still have seizures, we'll do it once a year, or how do you decide to do that?
So an EEG is a snap. I'm not sure which question to answer first. I'll pick the second question or second questions first, right? So an EEG is a snapshot in time. And if you're doing short EEGs, repeating it to get better information, more information, is a reasonable thing to do. If you're going to go for 24 hours or 48 hours and really capture quite a lot of data, and then that's probably something that doesn't need to be repeated unless there's a clinical change. I take somebody off of medications, or I want to. Are they going to be at risk for having seizures? That's one way of trying to assess that. Patients develop more symptoms, either if they have maybe more jerks during the early morning hours, or they have a breakthrough seizure, then you might want to repeat the EEG, especially if the first one was normal or negative, and there's more evidence of seizure activity. You might want to repeat the EEG. MRI is a gradually evolving field. We used to have 0.7 Tesla. Now we have one. Just the field strength of the magnet, it went from 0.7 to 1 to 1.5. Now the kind of standard is 3 Tesla. There are 7 Tesla magnets over in research centers. So you're going to get stronger and stronger magnets. You're going to be able to see at a higher level of resolution very small abnormalities. Whether those abnormalities are important or not in delivering care is a different question. Usually if you've had a really high quality epilepsy protocol MRI at a university center that does a lot of epilepsy work, that's adequate for quite some period of time. With one exception, and that is that there are sometimes subtle abnormalities, and we're not sure if they're a a cortical dysplasia, basically a small abnormality in brain development, or a low-grade tumor. And that question comes up, unfortunately, quite a lot. We will often get a repeat MRI in 3 months or 6 months to see if it has grown or not. But you don't really need to repeat MRIs every year or even every 2 years if things are clinically stable. To get to the first question.
You said you're at Hoag now, and you said to get one of those MRIs, you have to go to the university.
We do it at Hoag too. We had to kind of take those protocols to our radiologists and say, look, this is what we want done. They were already doing a very high resolution MRI work because they have a very big dementia program, and the protocols were very similar. So we only had to tweak a few things. We do them at Hoag. I know they do them at UCI, UCLA, USC. It's really just important to go someplace where there's an epileptologist, right? Because an epileptologist whose job it is to figure out where the seizures are coming from and whether medicine, surgery, VNS, RNS, dietary therapy is the best treatment option, they're not going to settle for a so-so MRI. They're going to know what they need. To get to the first question you asked, and that's really kind of a complicated, economically, politically complicated question, what often happens is when patients get referred from or self-refer from their general neurologist to an epileptologist, they don't often want to go back because they don't feel that, they suddenly feel like the person they're talking to has way more experience at diagnosis and management than the person that's been taking care of them for the last 6 months or year or 10 years. And that's a challenge, because if we never send those patients back, those community neurologists will never send us more. It's not, they lose patients. And sometimes they're quite good at delivering a high level of care in the community. And also there aren't enough of us to go around, right? So what I try to do is make as much of a change within a 6-month to 2-year period. And I tell patients that the hope is that we'll stabilize you, hopefully seizure-free, and you can return to your outpatient neurologist. Now that doesn't often happen because they don't really want to go back. Can you see them both? Yes, I do have patients that sometimes see their referring neurologist and me at the same time. You run the risk of too many cooks in the kitchen, right? And so you want to make very clear who's calling the shots and who's doing the follow-ups and what are we following up, who's checking the levels of the lamictal or the whatever it is that you're doing.
Sure.
Please.
Is it normal to continue to check the levels of medication? We've been going to a neurologist for 10 years, and we've never had the levels. He's never checked the levels again.
Actually, until we had a breakthrough, and then I said, could it be that she's grown and you've left her at this level of it?
That's an excellent question, and it's a little bit the answer is a little bit complicated. I often check levels, and I check levels on some medications much more often and routinely than I do on other medications. I almost never check a Keppra level because you can push it up to the point where they're either seizure-free or you've hit more or less the max dose, or they have intolerable side effects. And metabolism of Keppra isn't generally an option, a problem. Lamictal, on the other end of the spectrum, I find to be highly variable in how patients metabolize it. One patient might require 150 twice a day to achieve the same blood level that another patient requires 300 milligrams twice a day, to begin with. Number two, there are often interactions between lamotrigine and Lamictal and other anticonvulsant medications. And number three, and certainly with hormonal changes, we know in pregnancy, for example, the Lamictal level goes like that. I mean, it hits the floor in the third trimester, and you often have to triple the dose to maintain the same blood level. So Lamictal, I almost check every clinic visit. Layer on to all of those variations from individual to individual and hormonal cycles, particularly in women, that now we're in an era of generics. And as you know, the generics can have plus or minus about 18% of the actual drug and can be manufactured in a way such that they're absorbed quite differently from individual to individual. And we are also in the era of extended release formulations. And so I've had patients who I started on extended release, switched, and because they didn't tolerate it or breakthrough seizures, switched to the regular, did just fine. I go back the other way. It's a lot of trial and error, and it's a lot of checking levels, and particularly with Lamictal, but also with oxcarbazepine, also with Zonegran, also zonisamide, also with a lot of other medications. But I find lamotrigine to have the most variability in what you achieve in the blood level because of all those reasons. Yeah, in the back.
What's the half-life of Keppra's extended release?
It's supposed to be approximately 22 hours, I think, 22 to 24 hours. I mean, it's a once a day. All of the extended release formulations are intended to be once a day dosing. Not that the half-life of the drug is once a day, but they often just slow the release of the drug as it travels through the gut. That's how they manufacture it to become. That's how they repackaged Keppra to become extended release Keppra. And as I try to explain to my patients, it's hard enough to treat the differences in brains from one patient to another, but to treat the differences in brains and guts from one patient to another makes it even that much harder. So I have tended to stay away from the extended release formulations because I feel like I don't really have as much control over the blood level that I achieve. It's just a matter of preference. In case it hasn't been clear from other speakers, there's no one right way to do this. There's a lot of differences in clinical practice. So, yes, one who hasn't spoken yet, please go ahead.
I have a question. My daughter's on Keppra.
Yep.
And 2250 a day.
A day or twice a day?
A day.
Okay.
All at once, all at night. And still has breakthrough seizures. So her epileptologist decided that she has now exhausted the Keppra. But what he did was add in trileptal. Okay, so she just started that. It's not even been 2 weeks yet. So we'll see how that goes. But have you done that before? Have you seen, like, if you've exhausted Keppra and then you add in another a support med, do you see success with that? And then also with the trileptal, does she have to have her blood level checked as her weight changes? Because I know carbamazepine was like that when she was an infant or a toddler. Yeah. So.
Couple of different questions. I'll try to remember them For a normal adult patient, 2250 is not the max. I do have patients on 2250 twice a day. So for a teenager, it's certainly getting up there, but it's a situation in which I'd probably want to check a blood level and see where you are on the Keppra. Do I see success adding a second agent all the time? We wouldn't do it if we didn't. Trileptal or oxcarbazepine is the second generation of carbamazepine or Tegretol. There's a third generation, that's recently come out about a year and a half ago. There are another good 10 or 12 drugs and other things we've talked about as well. In particular with trileptal or oxcarbazepine, the issue is really hyponatremia. It's dropping the blood sodium. So that's a dose-related response. It affects half of patients, and it's okay. I mean, it drops it a little bit, but you don't have to do too much. But in about a third of patients, you get to a point where you don't have seizure control, Sodium is too low. You can give them salt tablets. Now you're treating side effect of one pill with another pill, and it's, I'm very acutely aware of the time when it's time to move on.
Yeah.
I'll take one more really quick one, and then I gotta go. Or I don't have to go, but there are other people who have to take my place. So yes, please.
My son is already about 2 years ago an adult dosage. He's already an adult dosage.
Okay.
About 2 years ago.
Okay.
And he's gained weight, and he's taller. And how would that affect, when I see his seizures after the VNS has lowered down, they have changed, they
Okay.
increase a lot. But how would that work if his seizures go back to the point that they were? He had Rasmussen.
He had what?
Rasmussen encephalitis.
Okay. So again, an unusual situation for a cause of epilepsy. I would just make sure you had a blood level of the medications that he's on at a time when he's relatively well controlled between the VNS and the medications.